Thank you. I just think we just ought to reflect just for a few moments before I start speaking, and particularly in respect of Raj and Vonda, who's with us. Thank you. Hundreds of thousands of patients are dying or being harmed by VTE in and following hospital admissions across the health systems in the world. We've known that this is a risk and what we should do for over 40 years. I'm going to share you a few moments of what we've done in the UK and how we still have, as Patrick says and Don Berwick says, a long way to go. In the UK, it required a patient politician-driven initiative 10 years ago and a subsequent parliamentary report to even start a national discussion with the medical profession on preventing deaths from VTE. It then required a national leadership statement from all professional colleges and bodies. We produced best guidance guidelines from the National Institute, as well as introduced a national risk assessment tool for all admitted and high-risk day cases. A salutary lesson here, I think. In 2010, the national risk assessment rate was 41% for all hospital admissions in the UK. And it took a financial incentive payment to hospitals to move to 90%, whereby we incentivize hospitals to increase the risk assessment to that level. We then stretched that goal to 95% a year later. And then we ceased the financial incentive. And it's now stayed at 96% nationally for 6 years, with over 16 million risk assessments carried out each year. So nearly 100 million risk assessments on this very topic. There's a long way to go. In England, we've started to see in small and large system studies that deaths from VTE are falling, but not as quickly as they should. Why is that? And what are the strategies that all systems should put in place to eliminate hospital-associated thrombosis? We have a range of preventative measures that are not universally adopted. Why is that? Is there an issue about commitment from our staff and systems to adopt best practice? If, why? Are we making the best use of technological advances? Are we ensuring best practice in communicating with our patients and between staff and our patients at times of handover? We have serious questions and principles to address. We learned from Don Abadian many years ago that systems and processes were important to deliver good outcomes. But he also stressed, and I believe firmly with many of you in the room, that it's the ethical principles of the individuals who work within a system that will ultimately determine whether or not that system will be a success. So our challenge is to ensure that those ethical principles are aligned to the benefit of our patients. The work I'm now going to present to you is the work of the panel and the work of many of those, particularly, as Joe said earlier, the force in the system is Ariana and Jordan, who helped develop and create our APSS for VTE. So I'd now like just to take you through that process, if I can find the prompter. But anyway, I can't, so we'll keep on going. Thank you. So first, I just want to take you through this, and then we'll have our panel discussion. And if you could bear with us, dinner will be stretched a little bit later, so don't worry, I'm not keeping you from your food. Our first issue was that hospital governance and senior administrative leadership must champion efforts in raising awareness around the high incidence of VTEs and prevention strategies. Healthcare leadership should support the design and the implementation of standards and provide training programs on VTE reduction and prevention strategies by acutely stratifying risk, by ensuring that providers perform a VTE risk assessment, by measure appropriately quality measures related to VTE to close any performance gap, to complete in-depth chart reviews, as was put forward earlier by Patrick, for hospital-associated thrombosis events, to adhere, most importantly, to best practices for VTE from national organizations such as AHRQ and the VTE Safety Toolkit, excuse me. The toolkit contains 10 components that are evidence-based for preventing, diagnosing, treating, and educating patients and providers about VTE. The components are as follows: VTE prophylaxis, risk assessment, diagnostic algorithm, PE diagnostic algorithm, HIT, and VTE treatment pathway. We should also ensure that the assessed risk for patients among patients hospitalized with a variety of different elements of injury to veins, slow blood flow, increased estrogen, chronic illness, and cancer in particular. Teleprompter's going mad trying to keep up, sorry. But also, critically, in terms of our current era, of increasing demographics with age, but obesity and coincidental central line infections. And most importantly, education for our patients and families on VTE risks and complications and importance of mechanical and medication prophylaxis. We should select technologies that show clearly evidence to reduce VTEs and positively impact both patient and provider outcomes in the clinical settings. And for many of you in the room, we should implement an EHR with prompt decision-making support, and we need to work with the industry to ensure that takes place. We need to have so that each patient has a valid prevention plan in place at all times during their hospitalization. Thank you. I'd now like to invite our panelists to join us on the celebrated couch across the piece. Thank you. Right, if I could introduce, in no particular order, Vonda, who I think many of you in the room will know, Steve from Massimo, Tim, Michael, and Brandon. Thank you very much. Sit down. I think I'm in the right place. Thank you. So, first of all, if I could start the ball rolling, really, and please ask Vonda just to share with us some of the insights that you've learned over the last few years, particularly since you've been spreading the word of the importance of not just a patient education, but of awareness of VTE within hospital staff.
Sure. Well, I'll start by just saying that being in a place like this, which I was a year ago, is inspiring to me. And I participated on the work group and continue to participate on the work group that developed the apps for the HAVTE. And two things stand out for me on there that I think were very relevant in our case, to be sure. Handoffs are, I think, maybe the 6th apps. Somebody probably has the number on that. We moved 8 times in, and forgive me when I say we, obviously this was my husband's experience. And as a caregiver there 24/7 for 13 days, it was our experience. And many family members and friends, students of Yogi Raja's, one of whom is in the room today. Those handoffs were opportunities, I think, for the kind of communication that I've noticed comes up in topics here. And then I think the piece on the apps that stands out the most for me is having a high level of suspicion. There was no high level of suspicion from my perspective with regard to those 7 or those 13 days. There were plenty of symptoms. And if in hindsight, I don't think anybody would look at the medical records and say, oh, well, it wasn't obvious. But as anyone knows, and I don't operate in hospitals. I didn't know anything about healthcare, and I didn't even know there was something called patient safety and that it was as big as it is. I'm glad, but none of that was on my radar. So I think education, and from my perspective, and Yogi Raj spent his entire life focusing on how do you create the presence of mind to do what we know to, or we think technically, or the data gives us information about, or we know what to do. Systems will improve when we learn how to do it. The presence of mind that we need to have in order to be more transparent, for example, not let our egoic power nature interrupt the relationship between the caregivers, the family members, and the providers, for example. Those are all things that stand out for me over the last several years.
Okay, thank you. I'd like to come back to 2 or 3 of those elements during our conversation, if that's possible. Can I just turn, I've just flipped the order a little bit on the basis of I can, so thank you. We had a planned setter here, but Brandon, can you just remind us of the scale of VTE harm and where you think that sits at the moment?
Absolutely, and certainly the numbers that we look at in the United States, somewhere around 300,000 to 600,000 patients here develop VTE every year, and more than 100,000 people die every year from pulmonary embolism. And that's more than the number of people who die from AIDS, breast cancer, and motor vehicle collisions combined. And it's a huge, huge preventable issue if we do the right things for patients. And one of the most disappointing things that I've seen, certainly in the published literature, there was an enormous study looking at practice across 32 different countries. And somewhere between 40 and 60% of patients are prescribed the right prophylaxis. So what that really means is that somewhere between 40 and 60% of the time, we're not doing the right thing for patients. That's what our real opportunity is to improve. And it's a global issue. It's not just a US issue. And it's something that I'm so thankful that the patient safety movement has decided to feature. Because unfortunately, blood clot prevention doesn't get a lot of press. You know, when I quote those numbers, I oftentimes think there are walks for AIDS, there are walks for breast cancer, but how many people have actually been to a walk for blood clots? It doesn't get as much attention as it should. And I'm really glad that we're able to talk about that today.
Great. Thank you, Brandon. And thank you. I think it's with and just to remind you, this panel has been brought together to answer some of your questions as well. So please feed the app so that I can ask them some questions later on. Some nice, juicy questions, please. Can I just now turn to Michael? So intraoperative stays and some of the problems and some of the concerns that clinicians have, or some of the things they should be looking out for in terms of determining how they should manage patients.
Sure.
And the use, going back to the issue of handovers and communication, I think, within teams. Thank you.
I think there's several topics there, which I'll try and address fairly briefly. One is it a never event? Should we be able to treat everybody and it should never happen? And I think the answer to that is probably no, but there's a lot more we could do. There are 2 therapies that we can do, and we always check on this at a timeout before we start a surgery. What have we done to prevent VTE? And it's usually giving heparin, or low molecular weight heparin, Lovenox, or putting on compression stockings. And everybody should get them unless there's a contraindication. So what could the contraindication be for heparin? Well, the answer is bleeding. And that is a concern, obviously, if you're doing major surgery, that perhaps somebody could bleed afterwards. And one of the tests that, and this is mainly for the clinicians in the room, one of the tests that's done to check if somebody's got a bleeding tendency is a test called INR, the International Normalized Ratio. And those of you who are on warfarin probably know that what your INR is, to see if the warfarin's effective. That prevents your clotting. But that's what that test was designed for, and only that particular area where somebody's taking this drug. Yet it's got in the medical profession translated over into a test for bleeding on everybody. And the liver is a smart organ. It makes molecules that make you clot, and it makes molecules that make you bleed, or at least keeps the blood flowing and doesn't clot. And it's a balance. So if the liver is not working properly, for instance, after you've had liver surgery, you do an INR and you'll find it prolonged. That's an indication perhaps this patient would bleed. And so many medical people have stopped giving the prophylaxis for a period of days until the INR comes back to normal. But in point of fact, the incidence of VTE in this patient group is the highest of all patient groups. And so we published about this a few months back, that you've got to actually look at the clot itself. Is that patient clotting? And you can do that very easily just by putting blood in a glass tube, or they're more sophisticated monitors. But you'll find that many of these patients that you think are going to bleed are actually hypercoagulable. They're going to clot. They're much more at risk, and you have to treat them with Lovenox compression stockings. And so that's number one, a big error that's made. The second one, and that's just education, the second one is, do you forget to put the compression stockings back on because you've got a patient up walking? So we have what we call huddles. And that is, every time there's a change in shift, it's a little like, it's like a handover that you just mentioned, but we get everybody together, the nurses, the physicians, at the handover time and discuss what are we going to do with the compression stockings? Where are we with the Lovenox? Do we still continue it? Plus, other apps come into this, like, is that central line still needed? Can we get it out? Is that urinary catheter still needed, or can we get it out? So we apply it to all these different things so you can reduce hospital-acquired infections, central line infections, as well as make sure that the proper prophylaxis is in place for VTE.
Great, thank you. Thanks, Mike. And certainly many of you in the room, I'm sure, are used to the huddle approach to gather and create momentum for local improvement too, I think, for anything that goes on in the local team. So that's a really important thing. Can I just ask, Steve, there are many other elements, though, aren't there, to embolic phenomena within the bloodstream? I'm just wondering and that cause harm. I'm just wondering if you'd like to just share with us your personal view on those. Thank you.
Thanks, I would. And in a way, I'm sort of the outlier here because our topic is venous thromboembolism, which is usually blood clots coming up from the legs. I want to call our attention for a moment to other embolic events that happen in the hospital that are almost always avoidable and often fatal. An embolism, after all, is anything that gets into the bloodstream that is not soluble in blood. And so it will block things. It will usually go through the right heart and get to the lungs, but there are exceptions that I'll talk about. So an embolism can include air, it can include fat, amniotic fluid, pus from septic areas, almost anything, and you think of it, it's probably ended up in somebody's bloodstream before. I want to bring this to life for you with some examples, a couple of cases, and I am watching the time carefully because I know that we are...
the clock is watching us too.
The clock is watching us, good. So here's a case that I was involved in. A 19-year-old Arizona football player is hospitalized for heat exhaustion. He was working out in the 105-degree temperature that we have in the summers. He had acute renal failure, but he's getting better. And in fact, he's already talking about getting back out on the football field within a month or so. He's down in radiology for a final study. His renal function is coming back. He has a central line. He's sitting up in his gurney. He's unsupervised, waiting to go in for his study. His central line gets disconnected from the IV supply, strike one. And this is something I'll come back to. Strike two, he's in the sitting position. Strike three, according to a witness who was there, he took a deep breath to say something. And he immediately went unconscious, was never heard from again. He was unresuscitatable. He was dead. Autopsy showed about 500 cc's of air in the right ventricle, When you do a large volume air embolism like that over a very short period of time, you basically put a vapor lock in the heart, and the right ventricle can no longer pump. The heart stops, it's done. It is basically instant death. Those events are almost always fatal. Air embolisms, smaller ones, are usually tolerated, but if they're large and very fast, that's going to be a problem. Next case. This was one that I was called to the room afterwards. Trauma patient, he's getting IV fluids to replace blood loss very fast. We use these pressurized systems, especially in the operating room, where we're basically squeezing the IV bag. There are about 6 of them on the market. You've seen them probably. They also warm the fluid. The IV bag runs out. However, in most commercial IV solution bags, there's about 200 cc's, 1 to 200 cc's of air in the top of the bag. Why do they put that there? So that people can read the level of the fluid as the bag empties out. There's a big strike. Strike 3 in this case, the safety valve on the warming pressurized device failed. The device pumped 200 cc's of air into the patient. Instant death. I am aware of at least 8 cases like that one with the pressurized IV systems. You would ask right away, I hope, why is there 200 cc's of air in the bag? Very good question. And by the way, as I do these cases, I'll do one more for you, because we're okay. Try to think ahead of me. What's coming? See if you can anticipate. One more. Let's do one more. Healthy patient has minor surgeries in the recovery room, 63 years old. Everything is going fine. The nurse accidentally injects about 5 cc's of air into his venous line. No big deal. Anybody can tolerate 5 cc's of air. That would normally go through the right heart, go to the lungs, be filtered out by the lungs, fairly rapidly absorbed. No big deal. But this patient immediately develops diplopia, double vision, severe headache, nausea, vomiting. He's rushed off to the MRI, and it's found that he has a tiny, tiny infarct in a very vulnerable part of his brainstem. How did this happen? Well, what happened, I think you're ahead of me, is what's called a paradoxical embolism. This air embolus, very small as it was, got across the atrium, the atrial septum, got over to the left side of the heart, which is very bad because when emboli go out the left side, they infarct vital organs such as the heart and the brain. How does this happen and why is it important to us? According to autopsy data, about 1/3 of all people have what's called a patent foramen ovale. That is, the membrane that separates the left and the right atrium that is open while we're a fetus and normally closes at birth doesn't completely close. And 1/3 of the people have it. That means in this room, there might be up to 100 of you who have this condition, and I doubt that any of you know about it. So this is something we should know about. We should find out which patients have it. And I think in general, the safe thing to do is just assume that everybody has it until proven otherwise, and be extremely compulsive and careful with our, with our IV hygiene, especially with air bubbles. I'll conclude. So as I said, there's a bunch of you in this room that have this condition and don't know about it, and you'll probably never know about it. And by the way, the patient I just described to you was myself. This was when I got very interested in these embolic processes. Yes, you wonder why. And I hope you will agree that I had a full recovery from this event, but we'll see. So, thank you. You know, life's little bumps do have effect on our direction, and this was a good one. Close call. So what do we do? What I've explained, I hope I got across, is that there are a wide variety of embolic events, not just VTEs, wide variety. How are we going to stop all of these things? Air embolism should never occur, never, ever. And the answer is we have to be obsessive compulsive in everything we do. I'm glad Vonda mentioned handoff communications. That's my other pet project that I'm involved in. And part of this obsessive compulsive means using checklists for everything. I'm an aviator, I'm a pilot. I believe in using a checklist for anything you can imagine and checking everything not once, not twice, but 4 times. And then collaborating. That's the strength of this group, the patient safety movement. We involve all of the people who are involved in the care of the patient, from the doctor, the nurse, to the insurance company, and to industry. Get industry to collaborate with us and make these devices more foolproof. Why should that CVP catheter be so easy to disconnect? It should never disconnect. So that should be a 0 event. So I'll stop there, but that is the strength of our group. I think we bring all these elements together and fix these kind of problems. Thanks.
Thank you, Steve. And Steve is here for the next 36 hours, so please use everything he has, all his knowledge base.
Please.
Tim, can I ask you just to reflect? So we've talked about checklists, we've talked about handovers, and we've talked about prophylaxis in our apps. And one of the elements that we've identified is that by carrying out good risk assessment, we should be able to zero in and give the most appropriate prophylaxis. Why isn't that working?
Yeah, thanks so much. I'm actually going to come back to something you said earlier, Mike. At the podium, you made the point about systems and people, really.
Yeah.
And one of the things that we learned early in our efforts at Mayo Clinic to really try to eliminate venous thromboemboli was we examined what were clinicians doing when they made the decision about venous thromboembolism prophylaxis. And what we found is that when they made a volitional decision, that they most often were correct. Mm-hmm. And so this was a key, that it wasn't for lack of education. What this speaks, and it wasn't for lack of motivation. What it really was all of the other things that get in the way of the day-to-day work. It was the lack of a system that could really help us. And so what we began to do, and I think this is part of the message of the app here, is when we began our work, we still were in a paper ordering system. And so checklists, you can design order sets and you can make it so that people are not able to get into your hospital without going through a checklist, in essence, that says, hey, think of this. But then as we evolved into an electronic order system, now you can begin to bring in a much more foolproof system. And so we saw right away us go from 60% to 85%. But getting to the people part of this, one of the things that we discussed at our team that was trying to design a much better system is we had the opportunity to just think a little bit about what would it take to actually make it so no one would die at Mayo Clinic from a pulmonary embolism. What would it actually take? And by using some of the quantitative tools that were available online, we could determine that, for us to get to the point where no one would die of a pulmonary embolism in Mayo Clinic, we needed to be greater than 98% reliable in delivering venous thromboembolism prophylaxis. That's what it took for our admission rates and so forth. And so we began to design, using our computer systems, computer decision support that would feed back after the decision would be made, modify the decision, and also surveil, because sometimes people come into the hospital and one thinks they're low risk, but after 3 days in the hospital, which maybe wasn't very apparent was going to happen, low risk is probably no longer an appropriate assessment. And so there's a need to change the plan at that point. And so what we're finding now is we have significantly decreased our frequency of venous thromboembolism, but we're still having some. And so I think this is getting to where, with the question you actually asked me, Mike, I cheated there a little bit.
No worries.
But what we're finding when we look at, so what actually happened that we still have some post-operative DVT and PE? And what we're learning are two things. First of all, people are very reliably making a decision to provide a plan for VTE prophylaxis, but they're not always making the right assessment any longer about the intensity that's required. There's about 25% of these patients probably should have more than one kind of prophylaxis. They should probably have both mechanical and pharmacologic prophylaxis. And the second part of that is that, unfortunately, because so many patients in an acute hospital setting these days are very ill and have some contraindications to pharmacologic prophylaxis, we must rely on mechanical. Well, mechanical prophylaxis doesn't work if it's not on. It doesn't work if it's not on. And it's actually very much an uphill battle to get everyone, the patient, the family, the people that we don't usually think of, not just the physicians and the nurses, but the physical therapists, the dietitians, the housekeeping staff, to get everyone focused on the fact that those sequential compression devices will not work when they are on the floor. They must be on the patient. And so that's a whole different kind of problem. It's no longer an IT problem. Now you have a people problem. You have a culture problem. And it's doable, and we're working on it.
Okay, thank you, Tim. There's just on this people issue, and it reflects a bit for Vonda's. There's a question here from a brave member of the audience, Amir Haider. And Vonda, I wonder if you could reflect on this first of all. And he asked the question: what can patients do to help prevent VTE? And I guess in this particular context, it's what can patients do to add vigilance to the local management of their case. What's your reflections on that? Because you were with Yogi for most of the time.
Yes. A couple of things that have been mentioned. One is communication. I'm a pretty strong person, and I'm not usually easily intimidated. I'll tell you though, I walked into that hospital, and whatever you guys said, I took it as the fact. So I think one thing that patients can do is remember that this is a collaboration going from the beginning. No one in the hospital tried to make me feel that way. I did that to myself. I did it because you're experts, and I wanted to be in a good. I wanted you to do not you specifically, but I wanted the experts to do their job. So I think that's one piece of it. Another piece of it is I think we can publicly educate. I'd never heard of DVT. I had no idea what it was. Yogi Raj actually complained about the mechanical, and I can't say that they were removed because he complained, but I can tell you for sure that if someone had said, this is a life-saving device, that's all the words we would have needed to hear. Mm-hmm. I would have made sure that every time that PT came in and I got that saddle next to me and we were walking down the hall, as soon as we got back into the room, I would have made sure that that compression device would have gotten back on. So I think that communication and education really go hand in hand there.
Okay, thank you. Thank you very much, Vonda. What's the future lie here in terms of, we talked a little bit about decision making and what is, in terms of an informatician, how are you going to help us?
Absolutely. And one of the most amazing things about VTE prevention, and we've certainly touched on this, in the field of patient safety, we oftentimes think of the Swiss cheese model approach to preventing harms from happening.
Jim Reeson.
Exactly. That there are so many redundancies in healthcare that only when all of the redundancies fail, that the holes of the Swiss cheese align, a patient could actually be harmed. And I actually think that it's the opposite for VTE prevention. And very much as Tim touched on and you did in the opening slides, in order to prevent a blood clot from happening, a patient must be risk assessed. The patient must be prescribed the appropriate prophylaxis for their level of risk. The patient has to be educated to understand why the prophylaxis is important, because a lot of times it involves a shot that's given 1, 2, or 3 times a day. And if a patient doesn't understand that, they might simply refuse. And the nurses also have to be engaged to administer prophylaxis as prescribed. And a lot of effort has been placed on the risk assessment and the prescribing side. In fact, I think a lot of the quality measures, both on a national and an international level, have focused on risk assessing patients and prescribing prophylaxis. But the second components of this, the administration and the education, are where we've been lacking somewhat. And there's an increasing amount of evidence that shows that in hospitals, 5, 10, I've actually seen 25% of prescribed doses of VTE prophylaxis are not administered to patients. And there are a number of reasons for this, primarily patient preferences, communication strategies, nurses saying, if you're up walking around, we can hold off on this 3 times a day shot. And that being the education, patients say, sure, I'd rather walk around than get a shot 3 times a day, particularly when it can result in bruising. So we've actually employed a data-driven approach as well as a patient-centered approach. My research group at Hopkins was actually funded by the Patient-Centered Outcomes Research Institute to develop patient-centered education, where we went out and talked to patients and said, how would you like to learn about VTE prevention? Paper, video, talking to a provider. What works for you? And we found a huge diversity in what patients prefer, so we made it all available. And we also tied into our electronic medication administration record, our EHR system, so that every time that a nurse documents that a dose of VTE prophylaxis isn't administered for whatever reason, that sends an alert to our study team to go out and intervene in real time, talk to the nurse, talk to the patient, make sure that everyone knows exactly what this is for and why it's important. And as a result of using data effectively, as well as partnering with patients and nurses in this regard, we've seen a reduction of non-administration by about 50%. And we're very fortunate enough to have PCORI fund us to spread this out to other hospitals as well, because it's not just one hospital's problem. It's actually something that we're seeing across the country.
Okay. Thank you, Brandon. Thank you. You're all very quiet on this machine here. I haven't seen many questions from you, so if you could think of a few. I'm going to start to add some extra ones in from me now. So I wonder if I could ask Michael to start, but then others to go around. Do you know whether or not the board of your hospital is aware of the risks that are attendant around VTE in your hospital? And how does that work? How do you make sure that the boards always are aware of the attendant risks of VTE?
Well, one, I'm absolutely sure our board is very aware because I'm on it,
Yeah.
and I make them aware.
Good plant, that one. Good plant. Yeah. What's your advice then for boards?
I think they've got to be very engaged in everything related to patient safety. And that's why they've all got to commit and get involved with us here in this group. And I think that's the message we've got to get out to everybody. Because if the board's involved, boy, it trickles down very fast. Okay. It really does. And it certainly made a big difference in our institution. That's where, in this timeout that we have before surgery, all these safety measures are gone through. And if the Lovenox dose has been missed because pre-op holding was rushed, they never got to it, it's picked up at that point because it's confirmed it was given or not given. And we don't go on until it's done. Same thing with the huddles. Again, that again came from the boards. That's what they wanted, was everybody to get together, the whole team, of what are we doing for this patient? And it's done twice a day as the shifts change.
Okay. Tim, the Mayo.
Excuse me. We have a very deliberate way of spreading quality improvement activities. So it's called discovery and diffusion. So discovery is learn someplace to do it well. And then after you learn someplace to do it well, you make a readiness assessment for, can we spread this to the rest of our health system? So we have 23 hospitals, and VTE prophylaxis actually was an enterprise-sponsored diffusion project. It was one that was selected early on. And so very definitely the Board of Trustees was aware of it and sponsored that kind of activity. I suppose it's a great question, because I'm not, if I went to the Board of Trustees now, I know that they would know about VTE prophylaxis, but it's not one of the things that we are actively diffusing now. We're refining it. So it's a little different stage of the project.
Okay, thank you. One of the challenges that we faced in the UK, certainly 10 to 15 years ago, was this whole basis of changing the way that doctors thought about it in particular. And it took a coalition between patients and MPs, actually, in our parliament to bring about some change. Steve, could you reflect on what are the politicians in this country doing to help support the reduction in VTE? harm.
Well, I think you're seeing some evidence.
We've certainly heard a
I
passionate
was
discussion earlier today.
going to refer to Joe Biden.
Yep.
He did an excellent job, and he's always been a great supporter of healthcare safety, as was Barack Obama, and many of the congressional members. If I didn't mention it, I'm an anesthesiologist, and there's at least one other anesthesiologist in Congress from District 1 in Maryland. We need to use those people as our key focal points to get the word out to the government. But I think, the evidence I'm seeing is that the government does want to help, not just in VTE, but in all of patient safety. We have seen a number of changes at my hospital, and I'll just mention, I always say that the first level of wisdom is to learn from your mistakes and don't repeat them. The second level, much higher level of wisdom, is to learn from my mistakes. And when I'm telling that to young doctors, I say, and I've been around a lot longer than you, so I've made a lot more mistakes, so there's a lot to learn from. I think that's where we can be helpful, and that's another strength of this movement, is that we make use of our mistakes and generate wisdom from that and spread it around. And
Thank you.
that has to go to government.
Before I come to Vonda, then to close.
I just want to follow up with the boards again too. One thing that our board does, and I think this is very important, is you've got to see the data. And we want to see every month the data. What is our central line infection rate? What's our urinary catheter infection rate? What's our pulmonary embolism rate? And that's very telling once you see the numbers. So you've got to collect data.
And I would love to touch on that as well, because I've sat through a number of very high-level meetings that convene on a monthly basis, and we get our dashboard of the current numbers on the hospital level, and we say, how on earth could we be doing this poorly? We need to go forth and do, and then we reconvene a month later. One of the issues and really opportunities for improvement, is that those numbers don't get to the frontline providers who are driving those numbers. And I'm not even talking about attending physicians, because anyone in a hospital knows that it's primarily the residents, the NPs, and the PAs that are writing orders, that are admitting patients, who are making the decisions about what to prescribe for prophylaxis. And when we talk about learning from our mistakes in a non-punitive way, are we actually telling frontline providers, this is your opportunity to improve? This is how you compare relative to your peers. And that's actually one of the strategies that we've implemented at our hospital, to tell residents how they're doing relative to their peers, and also how nurses are doing on administration practices, giving meaningful feedback. And every time that we ask a clinician to document something in the electronic health record, we're taking their attention away from some other aspect of clinical care. So if we're asking them to do that, we should actually be using the data that they're generating to drive performance improvement and quality improvement.
And I'll just respond to that, and that is, I feel we do, because we take each one of these episodes rather like a plane crash. In other words, every one of them gets reviewed, and reviewed with the whole team involved. And that then gets passed on to the next team, et cetera. So I think it does go right down. We really want to know, why did it happen? Where was the ball dropped? What could we have done differently? And the idea is we're watching those numbers come down, and it is working.
Thank you both. We started with Yogi Raj. Vonda, I'd like to give you the last opportunity. Can you just talk to us about what you would like the medical and healthcare profession to learn from your experience?
If I think about if Yogi Raj was in the room today, and it had been an error that was caught instead of a death that occurred, I know he would say, pay attention to what you pay attention to. But he had a gazillion quotes, and that was the one that never went into any job without being on a piece of paper. But when I listen to the panelists here and our work group and the work that we've done to this point, I think that it's important to kind of think about what that means underneath. It means what's going on. I was very inspired by Vice President Biden's words, and he basically gives us a playbook, I think, for my work anyway, to really look at what's under the surface. And I'll take a very concrete example in the medical records for Yogi Raj. There's a lot of cut and pastes. What was being paid attention to when a cut and paste happens? I don't know the answer to that, but I would be willing to bet that if we took some time to prioritize our presence of mind, we would be able to identify why cut and paste are a higher priority than writing what's happening in that moment. Why is it that we still have a myth that walking is prophylaxis? It's not prophylaxis, it's a good thing. And I remember the eyes on the doctor walking down the hall. He was so happy to see Yogi Raj walking. Now, he didn't say, you don't have a DVT, you know, we didn't know what a DVT was. But later, I can see these connections. So I think if there was one thing that I know he would leave us with and that I would want to leave us with, it's to look, in addition to all the wonderful things that we're doing around sharing data and systems, it's to elevate our presence of mind while we're doing that and in that delivery of care.
Okay, thank you very much, Vonda. Thank you. Patrick Conway also mentioned Don Berwick for lots of elements to him. I always remember working with Don closely in terms of supporting change in safety of patients in the NHS, and one of his other constants was that we all go to work to do our job, but we also go to work to improve how we do our job. And it's that second element of constant drive for improvement of how we do our job that I think is important here and to sustain ourselves in often a very pressurized time. Can I ask you to thank the panel for their contributions? Thank you.
Thank you, Mike. It's time for dinner. We're running really late, so I just ask that you please reflect on what you're hearing. Remind yourselves that being thoughtful all the time, being full-hearted all the time is key, and that we have to put process in place. I can't even imagine in my world, in the medical technology world, if there was a best practice and you didn't follow it. I think the gap between knowledge and practice is too large in healthcare, and we gotta close it. So let's go have dinner at the Pavilion. I know by now even prunes sound really delicious. And we have Dr. Thomas Zeltner, who also will give a very short talk, and you're going to wish it was longer because he's a very eloquent and knowledgeable speaker. So we'll see you at dinner. Thank you so much.